Thank you very much to all of you for staying because it's such a long day, and I will try and be as quick as possible. So I work as a nephrologist in England at the Sheffield Kidney Institute, and the reason why I'm here is that the Sheffield Kidney Institute is very proud to be a sister renal centre with the East Africa Kidney Institute in Nairobi. Okay? And the reason why I'm actually going to talk about hyperparathyroidism is that just behind this building, so this is my office here, just behind this building is the Centre for Metabolic Bone Research in Sheffield, which is a World Health Organization centre for osteoporosis research. So we did a lot of collaboration with them, and most of the stuff that I know about bone disease has really come from just talking to my colleagues in the building behind me. So I'm going to stick to three very simple kind of questions in my talk, which is why is controlling PTH important? What does PTH tell you about bone? And very quickly, just how would I manage secondary hyperparathyroidism? So you're all familiar with this cartoon that in CKD-MBD you have a range of mineral abnormalities that will lead to vascular disease and bone disease and increased cardiovascular death and increased risk of fracture. So that's the kind of paradigm of CKD-MBD. And this graph you've already seen in an earlier talk, so I won't labour the kind of point, but it's just important when you think about hyperparathyroidism, it's really important the interesting thing to note is that FGF23, which is the red line here, starts to rise really early on in CKD, so CKD stage 2. And then vitamin D and later on PTH start to rise in CKD3. So the mineral abnormalities occur very, very quickly. And if you want a really simple kind of approach as to why people with CKD get hyperparathyroidism, well, whatever's initiating the high FGF23, and it's still not quite clear what the initiating factor is, FGF23 will inhibit the hydroxylation and activation of vitamin D. And you know low vitamin D will then stimulate PTH secretion, and you know low vitamin D will then tend towards hypocalcemia, which will also stimulate PTH secretion. And then as you run out of tubules, so as your kind of kidneys scar up, you can't secrete phosphate. You can't secrete phosphate, and that will also stimulate hyperparathyroidism. So what happens if you don't treat PTH? So this is a patient. She's a 35-year-old lady who had spina bifida, so she wasn't transplantable, and she refused to take any medications, nothing at all. So she's on dialysis for years. She wouldn't take any medications. She refused parathyroid surgery. And what happened was she started complaining of a lot of bone pain, and this is her femur. And you might be able to see all these kind of lytic lesions and moth-eaten lesions in the lower end of her femur. So that's just bone loss, really. And again, here in the fingers. And if you do a bone scan, you can show really high turnover of bone. So this is really severe hyperparathyroidism that probably, if you talk to older nephrologists who worked in the 1980s before the PTH assay was used widely, they would see, but something that's very uncommon now. And why is PTH harmful? So this is some bit of research that we did, which is very simply just look at did high-resolution CT, okay? This is a patient with CKD who's got high levels of PTH, and this is a normal patient. And you can see, if you do CT, you can see more blue, so more holes in the bone, okay? So the bone is more porous, and if you have high levels of PTH, you eventually get kind of, you can show, you can quantify, you can get less, you have less bone density and less bone volume. So you have structural changes in the bone resulting from high PTH, and unsurprisingly that will contribute, although not necessarily cause, an increased risk of fractures. So this is a Canadian database in women, but the same kind of picture in men, which is as your CKD stage declines, as your EGFR declines, your fracture risk increases significantly. Okay? And this is DOPS data, again showing similar kind of thing, really, which is in the blue dots patients on dialysis. The red is the general population, and you see a much higher risk of hip fracture. Okay. And it's very difficult to know how to interpret this kind of data, which is very associative data, but if you look at patients with very low levels of PTH or very high levels of PTH, there is an increased risk in mortality. What that actually means in terms of patient management is very difficult to know. So I hope what I've showed you very briefly is I think the reason why controlling PTH is important is because high and low PTH increases your risk of fractures and death. And as you saw with the patient that I presented, very high PTH levels do eventually cause kind of fractures. So secondly, what does the PTH tell us about bone? Okay, so most of us will use PTH as a kind of surrogate marker for bone turnover, yeah? So if the PTH is very low, we think they've got kind of low turnover bone disease or perhaps adynamic bone disease. And if this PTH is higher, then we think they've got high bone turnover disease and perhaps very significant sort of high turnover bone disease. And if we think it's kind of in between those two, then we think, well, maybe the bone's normal. So how good is that kind of model or paradigm of how we use PTH? So this is a lady. She is on dialysis, 54-year-old lady. She's died now, actually. She was on alpha-calcidol, so that's active vitamin D that we use a lot of in the UK, calcium acetate and Cinacalcet, calcium mimetic. Her PTH was 3 times the upper limit of normal. Vitamin D levels were normal. Calcium and phosphate levels were normal. Okay? So, very quick question. Is the PTH level high, low, or normal? Is it just right? Anyone want to make a comment? Okay, so in the interest of time, I will just say that this is within the KDIGO target range. So most of us, I think, would say the PTH is just right. Okay? Now, what she did, which wasn't part of her clinical care, at the time we were doing a bone biopsy study, and she very kindly agreed to take part in a bone biopsy study where we gave her tetracycline labels, and that allowed us to assess her bone turnover rate. And what you can see, I'm not an expert in bone histomorphometry, but what you can see, this line here is an area of fibrosis, and here she's got some unmineralized bone or unmineralized osteoid. So she had both, in her renal biopsy, in her bone biopsy, she had both osteitis fibrosa, that's really high turnover bone disease, and osteomalacia, despite the fact that her PTH and vitamin D are in the normal range. Okay? So what that tells you is that PTH is okay, but not that good a marker for bone turnover. Because, of course, PTH just tells you what's going on in the parathyroid gland. It doesn't tell you what's really going on in the bone. And a number of other groups have found this. So this is a study in African Americans, where if you take this PTH range between sort of 2 and 8 times the upper limit of normal, some patients in the white bars will have adynamic bone disease, and others in the kind of grey bar will have higher turnover bone disease. So you can still have adynamic bone disease despite being in the normal range, or the target range, sorry, I should say, for PTH. One of the things that we kind of published earlier in the year was we found that when we combine PTH with other biomarkers, but perhaps most interestingly bone-specific alkaline phosphatase, we might be able to improve the prediction of the underlying bone disease. Most of us don't do bone-specific alkaline phosphatase because it's expensive. So the cheap way of doing bone-specific alkaline phosphatase is to look at the liver function tests. And if the liver function tests are normal, but the total alkaline phosphatase is high, you can be reasonably sure that it will be bone that's contributing to that. Finally, just one thing about the assays. There are 3 generations of assays. There's a second generation assay that most of us will use, okay? And this detects kind of intact PTH, but it also detects PTH fragments, okay? There's a stand in the tent outside selling third generation assays. So the third generation assay effectively measures whole PTH and doesn't measure the fragments, okay? And so because it doesn't measure the fragments, the results are 50 to 60% lower than the second generation assay. So you could say, why don't we all move towards a third generation assay? And the real reason is that most of the outcome data in terms of epidemiological research, it's all done with a second generation assay. So if we all move to third generation assay, it would be very difficult to interpret what our target ranges for PTH should be. The other thing is you really need to know which assay your lab uses. So this is data from Scotland, and each line represents 1 patient. And what they did was they took 5 commercially available kite-marked assays, and measured PTH on the same day in one patient. And you can see, for example, in this patient, the PTH can be very, very high, or it can be kind of in the target range. Okay? So when you get guidelines, so this is the NICE, which is a kind of guideline body in the UK, and the Renal Association, which is a guideline body in the UK, which is giving absolute values for clinical decision making for PTH. It doesn't make sense because it will vary from hospital to hospital depending on the assay you use. Okay, so this patient could get Cinacalcet, or depending on the assay you use, doesn't get Cinacalcet. So it really doesn't make sense to have guidelines that are based on absolute values. So what does PTH tell you about bone? Kind of not a lot really, but it's probably the best marker we have. Okay. Finally, how would I manage SHPT is what I'm going to talk about. So first thing to think about is, what about surgery? So this is something that we used to do a lot in the past and don't do very much now, I guess. The main problem with surgery is that quite often you're taking people with high turnover bone disease, you're removing all their parathyroid glands and then just giving them low turnover bone disease. So you're kind of swapping one kind of bone disease for another, okay? And it depends on how good your surgeon is. So this is our data in Sheffield, where most of our patients who had parathyroidectomies, this was about 10 years ago, had very, very low PTHs. And the problem is, if you have a very low PTH after a parathyroidectomy, your survival, that's associated with a much worse survival, okay? So unless you've got a really good surgeon who's very good at delivering this kind of target PTH level, parathyroidectomy is a really kind of difficult procedure to put your patient through. We all can give active vitamin D, and as you all know, active vitamin D suppresses PTH really well. So this is paracalcitol, alpha-calcidol, calcitriol, whatever vitamin D you use, they all work fine. The problems with active vitamin D are they increase calcium and phosphate. And although the makers of paracalcitol will tell you to use it, it's a lot more expensive, and there's no evidence that it's better in any way, either in terms of mortality or fractures or calcium or phosphate, than any of the other analogues, the cheaper analogues. Finally, Cinacalcet. Cinacalcet is a calcium mimetic. So what that effectively does is that it stimulates the calcium sensing receptor and makes the parathyroid gland think there's more calcium around than there is. Okay? And that's a very effective drug for controlling PTH. So this is a study from Belgium, I think, the Bonafide study, which gave PTH to people with CKD who also got bone biopsies at the beginning of the year and at the end of the year. Cinacalcet improves your PTH, unsurprisingly, but it actually, in quite a few patients, completely normalised bone histology. This is quite old data, but it's the largest study, and I'm sure many of you are familiar with this. This is the EVOLVE study that was published about 7 years ago now, looking at Cinacalcet in a large cohort of dialysis patients with hyperparathyroidism, okay? And this is the intention to treat kind of data, and you can see there was no real difference in death or cardiovascular events. If you change the statistical analysis, so if you do something that's called lag time censoring, you can get a different result. You can get a statistically significant result. But I'll just show you that just so you can look at the lines and make your own judgment about whether you think there's a significant difference. Similar kind of data with fractures. If you change the statistical analysis, you can get a statistically positive result, but clinically, it's very difficult to know if there's much of a difference between those two lines. What is good about Cinacalcet, unsurprisingly, is that it reduces your risk of parathyroidectomy because it controls PTH, which is a good thing, and it's associated with much less calciphylaxis, which is also a good thing. And cynically, I think that as the patent for Cinacalcet is running out, so Cinacalcet should become much cheaper soon. Amgen have introduced a new calcimetic, which is extremely expensive, etacalcetide, but that works in a very similar way and suppresses PTH in a very similar way. So in terms of management then, so what would I do? I'd control phosphate, whether that's with diet, dialysis, or binders, or a combination of all three. native vitamin D, so you want to correct native vitamin D, and I think the one thing I would say is that most vitamin D levels have been normalised for a kind of Western population, really, and there are big ethnic variations in vitamin D binding protein, which affects how you interpret vitamin D levels. So vitamin D levels are very difficult to interpret, and we don't know whether correcting vitamin D makes a difference to patient-centred outcomes. There's a study in the UK which is looking into giving native vitamin D to dialysis patients. Then my next line would be to give an active vitamin D. The downside is they will all increase calcium and phosphate. And then finally, add in a calcium mimetic if the cost allows. And as I say, you want to keep, the KDIGO would recommend keeping your PTH between 2 to 9 times the target range. And in the future, maybe using alkaline phosphatase or bone-specific alpha-9 phosphatase may give you a better guide of bone turnover, but it's not really ready for clinical use yet. Most importantly, as in all aspects of nephrology, you'd never treat numbers. Don't just treat a PTH, don't just treat a phosphate, treat a patient in front of you, because the benefits, you need to weigh up the risks and benefits.